where can they assign this client and not any of the others because are very complicated. Okay, more ABGs. Which client is most likely to exhibit the following ABG results? So I have a pH that is low. So this client have an acidosis. Now I need to determine if this acidosis is respiratory or metabolic. The CO2 is elevated, so it's high. So the arrow of the pH is low, and the arrow of the CO2 is high. Rom. So all the arrows are opposite, okay? So upset not having here a pencil to draw. And so habituated, okay, to that, okay? ROM, I use this mnemonic a lot. ROM stands for respiratory, the arrows are opposite. Metabolic, the arrows are equal. I said the pH in this client, the arrow is low, but the CO2, because there are two elements that I compared, pH and CO2, the arrow is high. So how are those arrows? Are opposite. So the letter that accompanies opposite is R of respiratory, okay? So this is a respiratory acidosis. This is a client with respiratory acidosis. Yeah, so returning to the question. No, yeah, I can hear. Returning to the question, my option, and also bicarb is normal and the oxygen is low. So obviously it's a respiratory problem. So the options are client with kidney failure. Kidney failure produce metabolic problems and specifically metabolic acidosis. Client taking hydrocodone. Hydrocodone is a commonly used opioid. Opioids have the potential of producing respiratory depression and hypoventilation. The hypoventilation produces retention of CO2, and the retention of CO2 produces acidosis. So probable this is the client. The client with anxiety disorder have the opposite as respiratory acidosis, have respiratory alkalosis, because the client with anxiety, the anxiety makes you hyperventilate. When you go to your Nclex, you are going to remember me. You are going to be in a very silent room because people cannot speak there. But then you are going to hear people, hyperventilating or making sighs. So are going to be. This happens when you uh, are anxious. You hyperventilate. When you hyperventilate, then you eliminate more CO2 than the needed. And for that reason, you develop a respiratory alkalosis. This is not an alkalosis, this is an acidosis. And clients with hyperkalemia not necessarily develop this respiratory acidosis. At least it's not the most common, okay? The most common hyperkalemia are cardiac dysrhythmia, okay? Cardiac dysrhythmia. So definitively, the client that have this acid-base disbalance is a client overdosed with hydrocodone, with respiratory depression. For that reason, the CO2 is elevated, the oxygen is low, and the pH is acid. If you want to talk a little more about acid-base diagnosis, and available. Another question about ABGs. A client with chronic renal failure is admitted to the ER. The gases are pH 7.32. This is low, so it's in acidosis. The PCO2 30, it is low. So the arrow is down, down are equal metabolic. ROM, okay, equal metabolic. So it's a metabolic acidosis. And it's confirmed because the bicarb is low. Okay, the bicarb is low. Okay, with this clinical scenario, which of these four symptoms or signs you expect to see? Bradycardia, hypotension, tachypnea, diaphoresis. So if I have a metabolic acidosis and the patient is alive, the patient needs to compensate. And the way of compensating metabolic acidosis is the Kussmaul respiration. Kussmaul respiration is a rapid and deep respiration. So the only thing that fits here in Kussmaul respiration is tachypnea. I expect tachycardia because the client is in distress. Not necessarily the blood pressure should be affected by the acid-base balance. And in client with chronic renal disease, the most common finding is hypertension. And diaphoresis is not a specific. Diaphoresis is something that is not a specific of anything. Even it's important to note that the clients in distress is not a specific of this condition. Next, a client is admitted with urinary sepsis, importante sepsis, and has a single lumen peripherally inserted central catheter line. Okay, the scenario is forcing me that for A, B, or C reason, I have only one catheter, a PICC line. 4 medications are prescribed for 9 a.m. and the nurse is running behind schedule. Which medication should the nurse administer first? So I have piperacillin, tazobactam, and L is missing here. The brand name Zosyn is very commonly administered for sepsis. Is very commonly administered for infections that occurs below the diaphragm. And yes, it's a very well-known antibiotic. It's the combination of penicillin. It is a penicillin, cillin. So that's why I insisted that it's missing here a typo 1L. It is a cillin, it's a penicillin. It's an anti-pseudomonas, an anti-gram-negative penicillin. So it's a penicillin of extended spectrum. But then it's combined with a substance, tazobactam, that prevents the penicillinase, the enzyme that destroys the penicillin ring, okay? Um, the enzyme that bacteria, especially gram-negative bacteria that produce gram-negative bacteria that destroy the penicillin molecule, that is called penicillinase, is inhibited by the tazobactam. So that's why I combine this potent penicillin with the medication, the other medication that protects the penicillin from being destroyed. This combination is very efficient, okay? It's very commonly used. Uh, is important for this client with urinary sepsis. This medication is given in a piggybacking. 100 milliliters of D5W have the dose of penicillin dissolved, okay, and must be passed in 30 minutes, okay, every 8 hours. The other antibiotic that have been prescribed for this client is vancomycin, 1 grams in 250 milliliters D5W to pass in 90 minutes every 12 hours. Both medications are due at 9. Enoxaparin is a type of enoxaparin, okay, 40 milligrams subcutaneous every 24 hours, and pantoprazole, 40 milligrams PO daily. But the question is very specific. It's the question of management, what you administer first. Knowing that you only have one catheter. It's 9 a.m. and running behind. I should know, I should know that my schedule, I have this, if those 4 medications are due at 9 a.m., I could start, I could start giving the medication at 8:30. And I can even give this medication at 9:30. I have half an hour before, half an hour after the due time to administer medications. Yeah. So I need, having one catheter, I need to favor the IV medication first. I need to start the IV medication first. So I need to choose between the Zosyn or the vancomycin. The other medication can be given in 1 second. Meanwhile, the IV medication is administered. So here the problem is which one is going to go first, A or B. The other ones are given any moment, okay, in the next half an hour because it's 9 a.m., okay, the 9 a.m., and those medications are due at 9 a.m. So if I start first the vancomycin is going to take 90 minutes, okay, 1.5 hours in passing. Yeah. So I need to wait 1.5 hours to then give the Zosyn. In that case, I will be initiating the Zosyn out of a schedule. So 1 hour later than recommended. But if I give first the Zosyn is going to be given in 30 minutes, so it's going to end at 9:30. And at 9:30, I can initiate the vancomycin, and at 9:30, I'm still in a schedule. For that reason, the first medication to be given is the Zosyn. Is going to at 9, start at 9, at 9:30 is going to end, and at 9:30 I hang the vancomycin to pass in the remaining. The due time for those medications that take a time to be administered is the time of starting the medication, not the time of finishing or ending the medication. So you need to start all those medications between 8:30 and 9:30. It is the correct. And you need to make the combination the best way possible. It is called management. And this is some of the questions that English can make. For people that don't have experience working as a nurse, it could be very challenging, okay, this kind of question. So summarizing, I start at 9, my Zosyn IV through the only IV line that I have. And while the Zosyn is passing, I'm going to give the enoxaparin, that is just a second, okay, subcutaneous, and the pantoprazole oral, which is another second. And then at 9:30, when the Zosyn ends, I'll start the vancomycin, and the vancomycin is left there passing, but was started on time. What started in the leeway, in the time that is allowed, half an hour before, half an hour later, of leeway for giving medication. Are we good? Yeah, those
Yes.
questions are not
Yes,
easy.
yes,
But
thank you.
then what you need to do, if you have a similar question, is start, playing. No? Okay, here the problem is the medication that need to pass in 30 minutes, 90 minutes. Okay, so the other one can be given in 1 second. Okay, the problem is the IV medication. Okay, what happens is I give first the Zosyn, and what happens is I give first the vancomycin. Oh, I got it. I got it. Good. The nurse is admitting clients to the same day surgery unit, which insertion site for routine peripheral venous catheters or peripheral venous access device, is the way that Nclex call this, does the nurse choose most often? So which part is more frequently used for the insertion of peripheral venous access device? So you have the back of the hand for older clients, cephalic veins, the forearm, lower arm on the side of the hemiplegia, subclavian vein. Nurses don't use the subclavian vein. So subclavian vein is reserved for doctors. Subclavian vein is an invasive procedure. You need to be a doctor, certified doctor, or trained as an advanced practice nurse, and it's a risky procedure. The main risk is arterial hematomas and the pneumothorax. So it's a no-no for registered nurse. Forget it. So easily you can cross out that. You know that the arm of a client with paralysis, with hemiplegia, should not be used. The same as the arm that have lymphedema or the arm that has an AV fistula in patients that are in dialysis. So AV fistula, lymphedema, and paralysis of hemiplegia are no-nos for nurses to initiate IVs. So you rule out this because you are supposed to know that. So you need to decide that if the preferred, the most commonly used is the back, the dorsal part of the hand, or the cephalic vein in the forearm. If you don't have this concept clear, maybe you have seen nurses to do a lot the back of the hand. Okay, the back of the hand is a very painful area to catheterize veins because in the brain the hands uh, are very extensively represented. Okay, I don't know if you've ever seen the homuncule that have a huge lip, a huge tongue, a huge hand, etc. Because are the areas of the body that you feel more. Okay, while there are other areas of the body you feel less. In the abdomen you feel too little. In the hand you feel a lot. In the forearm, okay, you feel too little. In the hand you feel a lot. And in old people, those veins that you see in old people in the dorsal of the hands are very thin veins that are very movable, so move a lot. So, okay, maybe you can get one vein, you can catheterize one vein if you are lucky. If you don't destroy the vein, you can catheterize, but it's not going to last anything. So that's why please don't choose A because it's not correct. The best place to insert a peripheral venous axial device that is going to last enough is in the forearm. You need to know that in the forearm you have two main veins, okay? Two main veins. So it is the thumb, and those are the other fingers, okay? Um, and this is um, uh, the arm. The one that is at the level of the thumb, the vein that comes here is the cephalic, and the vein that comes here is the basilic. Okay, you have here a median. Okay, a median vein that is rarely catheterized, and they make here. Okay, they make here like a Y. Okay, in the elbow, in the antecubital fossa. Okay, so this is the cephalic, the one that is at the level of the thumb, and the basilic at the level of the pinky finger. Okay, so those veins are excellent to catheterize, to insert catheters. You start inserting from distal to proximal. Okay, from distal to proximal. Uh, so the first, when admission, you put the catheter here. When the catheter need to be changed, it's moved to here, it's moved to here, from distal to proximal, but in the area of the forearms. This is the correct answer for this question. The dorsal hand of all people is not good to catheterize vein. So it is the best answer, cephalic vein of the forearm. An older client, adult child. So the son or the daughter or the child of an adult client tells the nurse, this is for people like me that don't speak English as first language, is confusing. Some of you are in my situation. So the child of the adult client tells the nurse that the client does not want life support. It is something very important. No, the clients want to be DNR, etc. Can be left to hospice or whatever. What does the nurse do first? Call the legal department to draft the paperwork, document this in the chart, thanks the child, and do nothing else. And don't do that. Talk to the client. Obviously, if the client is adult, the one that needs to speak is the client, not the children. So obviously, you need to go to the client and find that if it is exactly what the client is wanting. You want to assess if the client is aware of the consequences of not uh, opting for life support in case of needing, etc., etc. And then is when you can escalate that to the physician, because the physician is the one that can order the DNR, or do not resuscitate order, and orders for hospice, etc. Okay, so this is the protocol. So first you need to go to the client, not to the, don't accept, okay, the child statement without verifying with the client. Okay, easy one. During a pre-operative assessment, which is statement by the client requires further investigation by the nurse to assess surgical risk. Okay, what the question is asking, what could increase the surgical risk of a client when you do the pre-op assessment? What said the client that increases the surgical risk of the answer of the clients? I'm taking vitamin C, no problem. Vitamin C doesn't interfere with the surgery. By the contrary, okay, favors the healing. I drink one glass, a glass. A is singular, is used for singular, one glass of wine a night. It is okay. If it is a male, it doesn't say the gender. It is a male, it's half the recommended dose. If it is a woman, it's the recommended dosage. So no problem with that. In my experience, when I use a similar question like this, the majority of the students answer this. Guys, you need to accept that is considered healthy to consume one dose, one portion of alcohol daily. You not accumulate them for the weekend, okay? Daily, okay? You get to spread that daily for women, and 2 doses for men. One dose is one glass of wine, or one can of beer that has 320 milliliters, something like this. Um, one shot, I mean 1 ounce of spirits, rum, whiskey, bourbon, vodka, etc. So those are one dose. For women, one daily. For men, 2 daily. Men can metabolize the alcohol more efficiently than women. Okay, so there is no risk in this. I had a heart attack 4 months ago. Of course, this is a huge risk. Surgery soon, during or soon after the heart attack has very high risk of complicating with ventricular dysrhythmia during the surgery, during the anesthesia. So this is very serious issue. I don't like latex balloon. The fact that the client doesn't like latex balloon doesn't mean that it's allergic to latex balloon. It is a distractor that you need to understand. Yes. So C as in cat is the answer of this question. So remember it. Okay. The other risk factors for surgery is being an active smoker, or having very low hemoglobin. A hemoglobin that is less than 9 or 8 is as a risk factor. Okay, well, there are other risk factors, but mainly those. Okay, for surgery, having a recent ischemic heart attack, being an active smoker, and having very low hemoglobin are important factors that increase the risk of complication and even death during surgery when you receive general anesthesia. And are the most commonly tested. If a sterile gas falls to the ground and hits the front of the surgeon's gown on the way down, what should does what does the what should do or does the nurse what does the nurse do to ensure proper infection control? Okay, so you need those in those questions to close your eyes and see the scenario. The surgeon, the doctor, is wearing an sterile gown, and then an sterile gauze accidentally falls. Then the gauze in the fall is going to touch the sterile gown. So sterile is touching sterile, no problem. And then the finally, eventually, the gauze is going to fall in the floor. Now it's not sterile anymore. So the question say, so now you visualize what is described there. What should do the nurse? Okay, help the surgeon change the gown. No need. Why no need? Because sterile touch sterile. Picks the gauze up with a pair of sterile gloves. No, you don't need to pick this gauze with a sterile glove. This gauze is already contaminated. You don't need to wear sterile gloves to pick up the gauze. Yes? Pick the gauze up without touching the surgeon. Oh, this is correct. Don't touch the surgeon. And yes, pick the gauze up. Sprays an antimicrobial on the surgeon gown. No need of that. Okay, so the answer is C. Those are only you need to understand what you are reading. A nurse is teaching a client post-operative breathing techniques using the incentive spirometer. How we use the incentive spirometer. Remember that it's a treatment. Incentive spirometer is used as a treatment to prevent atelectasis and pneumonia especially after surgery with general anesthesia, but could be using any client. Okay, very good. What should the nurse encourage this client to do to maintain, okay, a sustained maximal inspiration? Exhale forcefully into the tubing for 3 to 5 seconds. So blow, exhale forcefully is blow into the tubing for 3 to 5 seconds. I don't like yellow. Okay, 3 to 5 seconds. Inspire, breathe in deeply and slowly over 3 to 5 seconds. Breathe into the spirometer using maximal breath volume. It means breathe in and breathe out. Inspire deeply and expire through pursed lips every 6 hours. Okay, so what we do when teaching the client uh, 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 how to use an incentive spirometer. The first that you need to understand is that I don't know why when I ask students what should be done with the incentive spirometer, if you blow in the tube in the incentive spirometer or you suck, you breathe in through the incentive spirometer, a lot of people say you blow. You do not blow in this stuff. This is not a trumpet. It is not a whistle. Okay, is to suck air through the incentive spirometer through the device. While you are sucking, while you are introducing air in your lungs through the device, you'll see how a marker elevates and reaches a level that is the desired level. Each time you elevate more and more this marker, uh, incentivizing is a motivational, okay, a machine, the client to each time breathe deeper and deeper. So the purpose of this device is just psychological. Is psychological. Is that because you have a marker that visually elevates when 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 ¿cómo se llama? When you breathe in, you can, it's like a competence, being motivated to each time suck more air, breathe in more air, more volume of air. Even if you are experiencing tiredness or pain, it's like a psychological motivational device. That's why it's called incentive, speedometer. So it's to breathe in, guys. The purpose of breathing in is to feel the lungs at the maximum, okay, possible, each time more and more, to expand the alveoli, especially the alveoli at the level of the base of the lungs, of the lung bases, because those alveoli, after general anesthesia, tends to collapse, emptying of air, producing what is called atelectasis. And those atelectasis produce hypoxemia, and produce increased risk of pneumonia. So the purpose of the incentive spirometer is to incentivize the client to breathe in deeply. So the best option here is option B, is inspire deeply and slowly over 3 to 5 seconds. Then when you finish the inspiration, you remove the stuff, the mouthpiece from your mouth. Try to hold the air as much as you can, 5 seconds, 10 seconds, and then breathe out slowly through pursed lips. This is the way that you need to teach the client to do that. And this should be done 6 to 10 times per hour, not every 6 hours, 6 to 10 times per hour. Okay, so that's why you rule out the last option. And it's not to blow, it's not to exhale forcefully. So you eliminate A because it's to breathe out, exhales forcefully. You eliminate D because is every 6 hours, no, is every, okay, is 6 to 10 times every hour. And then breathing in and out through the spirometer is not the purpose, okay? The purpose is be inspired, is to fill the lungs as much as possible with air. No problem, no? There is a lot of problem.
No.
There is a lot of problem. People confuse that the incentive spirometer is to blow. Never to blow. Blowing empties the lungs and favors the development of atelectasis. The idea is to breathe in. During assessment of a client with an intracapsular hip fracture, on the affected side, the nurse should detect, okay, this is, even in Nclex, is with a picture. A client who fell and have one leg shorter than the other with external rotation of the foot. So the answer is shortening. Yeah. There is no muscle flexidity. By the contrary, when you have a fracture, there is a muscle spasm in the area of the fracture. This muscle spasm is going to overlap, or I don't know how to say in English. It's going to overlap one fragment of the bone over the other. The two fragments that have been severed, that have been fractured, are going to be lying or overlapping one over the other, because the muscles is contract, moving the fragments one over the others. That's why the extremity will shorten. Is the explanation why the extremity is seen shorter, and the foot is going to drop to the externally. The rotation is going to be externally. So trying to put your great toe falling out, falling, rotating out. Okay, and this is what you see in those clients. Numbness is variable. If there is numbness, it is a complication. There is a nerve compression in the fracture, and it's transformed the fracture in an emergency. And internal rotation, no, it's external rotation, shortening. Okay, there is a question in Nclex that the client had the surgery, so the client went to surgery because those clients can have a traction. Okay, this was a question recently in Nclex. Why they put this client in traction? Okay, now I can represent the fracture. No, the fracture. Okay, the bone is suppose that is not a hip fracture. Is not a ¿cómo se llama? A intracapsular fracture. Is que fue me quedó ese. Okay, is a shaft fracture. Then you have this phenomenon. You have the two fragments, okay, overlapping one over the other because the muscles that are here, the muscles are here, okay, you know, develop as a spasm, so they contract because they develop as a spasm, yeah, and they are going to approximate one fragment over the other, and that's why there is shortening of the extremity. So they are going, okay, to here comes all the bones, and here's come, okay, the foot. They are going either through skeletal traction. For the skeletal traction, they are going to introduce a pin in the bone. In reality, not here. It's going to introduce here. Okay, let me change this. It's going to be introduced here. A pin is introduced in the bone, okay, in the bone with a drill, and then it's going to be tied to ropes, okay? It's going to be tied to ropes, okay? To ropes, okay? Ropes that go, okay, to a pulley, to a here is to a pulley, okay, a pulley, and then the rope is going to have a weight hanging freely there, a weight hanging freely there. This this traction is going to pull the extremity in this direction. This is going to produce that the spasm of the muscle is going to be overcome, is going to be defeated, is going to be surpassed by the traction, and then the fragments of bones are going to realign because the muscle is going to be stretched, by the traction. You understand? So summarizing, what is the purpose of the traction? The purpose of the traction is to overcome, to over surpass the contraction of the muscle, okay, with the traction, with the weight that is pulling in this direction, in a way that the muscle is going to be stretched and the fragments of the bones that were overlapping are going to be realigned and kept in this position. So is to overcome the muscle spasm and realign the bone fragment. Okay, this is the answer more or less that you need to, to look for in the options. Remember that this weight need to be 100% of the time, I mean all time, freely hanging in the air. So if this is the bed, okay, the bed, those are the legs of the bed, okay, the legs of the bed, this is the floor, okay, always the weight need to be freely hanging. There is no problem when you move the bed if the weight move, if the weight is balancing, okay, from one side to the other, no problem. The pulley is going to cancel this movement in this part, because it was in one question that what was wrong is that when they moved the bed, the the weight was moving side by side. No problem with that. And but never you can put this in a chair or put it in the bed, etc., to move the client, etc. Always you need to have this freely hanging. um there is an alternative to the skeletal traction, that is to wrap the extremity, okay, with fabric, elastic material, can be a boot, can be etc., and then they don't need to penetrate the bone. The traction is done pulling the ¿cómo se llama? The leg with this and this is called the box traction, which is the most commonly used, the box traction, which is an skin traction. Of course, it's less invasive, less risk of infection. So the previous was a skeletal traction, that there is risk of infection because it's invasive. You have a drill through the bone, versus the skin traction, that the most common is the box traction. When you have a traction, it's important to understand that you need to do a counter traction. So you have a force that is pulling in this direction. You need another force that keep the client in this position to do the counter traction. And what they do for that is to either elevate the foot of the bed, which is going to hold the client in position, or place here a wedge, okay, that um, keep the client. Okay, the client is going to slide, and is going to be stopped by this wedge. It's important that always the heel need to be floating in the air. Never should be making contact with the mattress. Okay, you can do that with a wedge, or you can pull here a, a cushion or a pillow under the leg, never under the popliteal area, never under the knees, because it produces DVTs. It's under the leg to have the heel floating. Okay, those are the questions that I seen of traction in Nclex. Okay, if you are interested in this topic, and of course it's also med surg. The traction. Those tractions are transient, are not permanent, are no long lasting, are transient. Is meanwhile the client waits for their turn to go to OR. Fractures are not emergencies unless there is compartment syndrome or bleeding. But yeah, no, it's not the fracture, it's the compartment syndrome or the bleeding, the emergency. Fractures need to wait for surgical turn to surgical disorder, and sometimes need to wait days. Meanwhile, they are waiting for the surgical turn. They are in traction to prevent that. Okay. Okay, this is what comes to my mind suddenly about questions that have been in English, and I want to share with you. Precisely this question about what is the purpose of the traction was recently in one student test. Exactly how the question was, no, but what you need to know or content to deal with this question is to understand the purpose of pulling, okay, the two fragments of bone to realign them, overcoming the contraction that makes the muscle, the spasm of the muscle. The home health nurse conducts a community presentation on Lyme disease for the residents of an assisted living facility. Assisted living facility con Lyme disease. It is okay. This is the question. You need to dance with the music that the orchestra is playing. So if they make this question, suppose that they make this question in English, you need to accept Lyme disease in a nursing home. Which statement from the audience indicates to the home health nurse that further instruction is needed? What is wrong about Lyme disease? And I'm commenting that because I expect Lyme disease in people that work in forest, in in the ¿cómo se llama? The industries related with forest, okay? Um, or individual that for for pleasure, for sport, for vacation, whatever, visit the forest because it's the classical situation because the ticks are not common in the populated areas. The ticks are common in the forest, okay, in the forest. And people need to enter in the forest for camping, hiking, or for work in the area. And this is not the classical person that I find as a resident of assisted living facility. For that's why I was surprised. It doesn't mean that these people could, in the past, in their youth, work in those areas or visit those areas and can be now suffering the chronic forms of Lyme disease. Okay, it is a possibility. So now, one client says something that is wrong. So they say, I will remove the tick as soon as possible and then burn it to prevent the spread of the disease. The tick should be removed as soon as possible. So when the people return from hiking, camping, or working in the area, the people should check, uh, uh, assess their skin for the presence of attached ticks, because it is said that if you remove the tick before 24 to 48 hours of the attachment, you prevent the disease. So the the primary prevention is not allowing you the tick to bite you. How you avoid the tick biting you? Well, wear clothing that covers you completely. So long pants, tuck inside the socks and long sleeve. Use clear colors because the dark colors attract the ticks. It was in English. It was in English, this detail. Spray your cloth with repellent. Okay, the most commonly repellent used is the DEET. D as in David, E of Edward, E again, and T. Okay, and DEET is an insect repellent that is not toxic. Can be used for either for mosquitoes and for ticks. Mosquitoes, if for mosquitoes transmitted disease like Zika and the West Nile virus that is in English. West Nile virus is in English and is transmitted by mosquitoes. Here we're talking about ticks. Um, check your dog when you return, so has no tick attached, and check yourself to see if you have any tick attached. If you remove the tick before the 48 hours, then you are preventing the disease because the ticks requires time, around a couple of days, to introduce the bacteria in your body. So stay attached to your skin to introduce the bacteria that produces Lyme disease. But once you remove the tick, don't crush or burn the tick, because if the tick has inside the bacteria is going to be spreaded, and still you can get the bacteria. That's why they don't want you to crush, okay, the bacteria, the tick, nor neither to crush nor to burn the tick. You need to flush the tick in the toilet. Yeah, flush the tick in the toilet. it is not necessary to save the tick for being examined. It is not part of the process of diagnosis of Lyme disease. Examination of the tick is not part of the process. So it's the information about the tick. So one A is incorrect because it's burning the tick, which can burst and spread the bacteria. Second, it is best to walk in the center of the trail. It is true. Separated from the grass and scrub. It is true. Because the nymph of the tick that are waiting for a mammal to pass and jump and attach to the skin usually are in the grass and the scrubs and the the shrubs that are there. And if you are walking in the center of the trail, you avoid the ticks. So it is true. It is true. See, I should wait 4 to 6 weeks after being bitten by a tick to be tested for Lyme disease. It is true. There is a test, a blood test, that tells the doctor if you have been infected by the bacteria, the Borrelia, uh, um, that produces the Lyme disease. But it is a test that detects the production of antibodies by your body against the bacteria. And because the production of antibodies takes a while, there is a window period of 4 to 6 weeks, okay, to determine the rates of the antibodies. And for that reason, it is true. Uh, the test is not done immediately. The client is bitten, or even immediately after the rash, the classical rash, if appears, okay, it appears. And the last say, I will wear light colored clothes with long sleeve, long pants, clothes, shoes, and hat when I'm walking. It is correct. So because we are looking for the one that is wrong because we are mortician, A is the incorrect because you should not burn the tick. Okay. A little review of the Lyme disease. Remember, the Lyme disease is treated with tetracyclines, doxycycline. And in case of allergy of tetracycline, or in the chronic forms of the Lyme disease, then they use penicillins or cephalosporins. Okay, penicillins and cephalosporins are the second line. Okay, antibiotics used for the treatment of Lyme disease. Everybody knows the the target or bullseye lesion that frequently appears in pictures in the test. Okay, but the other theory is this. Next, the nurse is teaching a client about the difference between rheumatoid arthritis and osteoarthritis. Okay, it's a common topic. Okay, both in MedSearch and Nclex. They are the two most common forms of arthritis, but are totally different. The rheumatoid arthritis is an autoimmune disease. It is a disease in which the immune system gets confused and produces cellular immunity and humoral immunity. Let's see, antibodies, defenses that are confused and attack the body of the person, specifically the joints of the person, destroying those joints. It can happen even in children or adolescents. Okay, not necessarily is it old people disease. By the contrary, the osteoarthritis, you need to understand that in the joints, you don't have bone. The joint is a space between bones. You need to understand that. What is a joint? In the joint, you don't have bone. The joint is the space that separates the bones. The bones must be separated, and there should be there an empty space that allow the two bones to articulate, to move. Yeah. Nevertheless, to keep the bones separated, you need a structure, a tissue called cartilage. So it's the articular cartilage. The cartilage is a form of tissue that cannot regenerate. There are some tissues in the body like nervous tissue, neurons and muscular cells and cartilage that are not able to regenerate. Once you reach the adult age, those cells cannot regenerate, cannot go to mitosis and regenerate. And this is one of the tissues, the cartilage. So you have those joints and you are using those joints moving all the time. And what is separating the bones is the cartilage. So you are wearing and tearing those cartilage along years and years and years of use. At the beginning, as the majority of you, those cartridges are perfect and you don't feel any problem. But when you reach my age, then you start noticing that some of the joints that you used the most, more frequently, are, are developing, loss of this cartilage because wear and tear. And then the bones start touching bones. And then I start experiencing pain. And this is the osteoarthritis or degenerative joint disease. So now you know that the option A, that rheumatoid arthritis is inflammatory because inflammation has to do with immunity and is an autoimmune disease. Inflammation is the first step of defenses of the immunity to protect us from infections. Inflammation implies uh, pain, swelling, warmth, and erythema or redness. Yes, this is inflammation, the four cardinal signs of inflammation. While osteoarthritis is not necessarily an inflammatory disease, it's a disease of wear and tear of the cartilage, the articular cartilage. So it's more defined as a degenerative disease. The so A is true. The risk factors or causes of rheumatoid arthritis are probably autoimmune. It's true. Whereas osteoarthritis may be caused by age, yes, because wear and tear after many years. Obesity. What is the problem of obesity? Which joints are supporting my overweight? My hips and my knees, especially. That, by the way, are joints with very complex cartilage that are very susceptible to wear and tear. Hips and knees. That's why there are so many clients, all clients, having hip replacement and knees replacement because they wear and tear. If you have a truck and you put tires, a Volkswagen tire to a truck, obviously the weight of the truck is going to burst the Volkswagen tires. It comes, if God designed me, my knees and my hips to weigh 150 pounds and I'm weighing 200 pounds and overusing my knees and my hips with 50 pounds extra. So that's why obesity is a risk factor for osteoarthritis. And it's an important concept. You can have a question in Nclex, which are the risks that brings obesity. And then you have diabetes, hypertension, coronary artery disease, and then you have osteoarthritis, degenerative joint disease, especially of hip and knees. And you know that is true. So it is true. Trauma and occupation, of course, is important. If you have a trauma, uh, can damage the cartilage, and if your occupation, so I can imagine, I don't know, a, a, a pianist, okay? A pianist is going to have wear and tear of the joint of the hands more sooner than I don't know other person. Okay, very good. Uh, Next, the typical onset of rheumatoid arthritis is seen between 30 to 45 years of age, whereas the typical onset of osteoarthritis is seen in clients older than 60. It is true. The rheumatoid arthritis being an autoimmune disease is seen more frequently in women than in men, as most of the autoimmune diseases, and is seen in comparatively younger people. And yes, it's true, the majority of the clients that develop rheumatoid arthritis do that in the third to fourth decade of their life. But osteoarthritis is, I raise my hand, a disease of older people. So it is also true. So I'm looking for the wrong, so it needs to be the last. The disease pattern of rheumatoid arthritis is usually unilateral, or it is wrong. The rheumatoid arthritis is very symmetrical. I have two knees, I have two hips, I have two ankles, I have two wrists, I have two elbows, two shoulders. Yes, the rheumatoid arthritis affects bilaterally. So affect my right and left, each one of them that I mentioned. By the contrary, osteoarthritis, degenerative joint disease, usually is asymmetric, affects much more one joint than the other. So for example, my bad knee is the right knee. The left is okay. Yeah. And the most affected hand, my most affected hand is my right hand and my right, wrist. Okay. Probably because are the one that I use more because I'm right-handed. You understand? So it is wrong. The osteoarthritis is asymmetric and the rheumatoid arthritis is symmetric. So all the contrary, okay? All the contrary. The rheumatoid arthritis affects practically all the joints, so many, many joints. The degenerative joint disease are oligoarticular, so affects much, much less joints. Okay, so a little learning of is this in Nclex? Yes. Okay, should be known the difference. There is an element that is not mentioned here of rheumatoid arthritis is that there is a lot of stiffness, muscle stiffness, and joint stiffness uh, after rest. So in the morning, when the client with rheumatoid arthritis wakes up, it's going to be extremely pathologically stiff. And any movement is going to be very difficult and very painful. And this stiffness is going to last more than 1 hour. By the contrary, the osteoarthritis don't have this level of stiffness. It is a big difference and should be mentioned. There are many questions about how a nurse can improve the stiffness of the client with rheumatoid arthritis. The answer is heat. The application of heat, okay, hot showers, etc., shorten and improve the stiffness of rheumatoid arthritis. The treatment of rheumatoid arthritis versus osteoarthritis is other big difference. Rheumatoid arthritis can uh, um, disable a person. For that reason, the treatment must be very aggressive. If a person of 30 years start developing rheumatoid arthritis when this person is 50, is going to be in a wheelchair, total care, totally depending of other people for their ADLs. To avoid this, the treatment is very aggressive. The treatment is basically with immune suppressors. Uh, of course, the glucocorticoids can be used, but you know all the side effects of the glucocorticoids. So they are going to use medication that are immune suppressors, but are not glucocorticoids. They're called steroid, saving immune suppressors. The most important is the methotrexate. Methotrexate is the first line immune suppressor used for rheumatoid arthritis. but also other immune suppressors like the modern biological modifiers like the monoclonal antibodies, the adalimumab, el Humira, infliximab, okay, etc., can also be used. By the contrary, for rheumatoid arthritis, for osteoarthritis, for degenerative disease, the only thing that the doctor prescribes you is Tylenol, is acetaminophen. Yes, acetaminophen at safe doses. The type of exercise convenient for people with any type of arthritis is low impact exercises. What means that? That those are exercises that are not going to make the joint support intense trauma, intense forces. Like, for example, running. When you are running, okay, there is impact in your hip and in your knees and in your ankles. This is not good. It's not good for clients that have arthritis. Yeah. So low impact is, for example, uh, swimming. When you are swimming, you are floating, and your joints are not suffering the impact of the gravity force when you fall. Okay, when you are running, etc. What else? It could be yoga, tai chi, etc. Okay. Another question, because comes to my mind so many questions that have been in Nclex related to those two diseases that are so frequently tested in Nclex. A client with an acquired immune deficiency syndrome, so AIDS, is seen in the clinic for re-evaluation of the immune system response to the prescribed medication, the antiretroviral therapy. Which test result does the nurse convey to the healthcare provider? Let's see, let me read, okay. Let's add here as a priority. So summarizing, I have a client that is known for being HIV positive, has acquired immune deficiency, is coming to the clinic for evaluation, and have a four test, has the titers or blood levels of the antiretroviral medication that is used, uh, the HIV ELISA and Western blot test, the Papa Nicolau test, and the CD4 count. Okay, so these four tests. And the question say, of these four tests, which one you report as a priority is the most important? Blood levels of the medication, HIV, ELISA, and Western blot is positive. Papa Nicolau test is positive. CD4 count has elevated and the viral load has decreased. Of these four tests, what have priority, guys? Help me.
C as in cat?
C as in cat, okay? Because the clients have cancer. The other is known, the other is expected, yes. So all are important, but the priority is that the client has cancer. Remember that cervical cancer is more frequent in clients with HIV. And for that reason, it's very important. And the cervical cancer in clients with HIV is very aggressive. It's one of the cancers that behave very aggressively. So yes, you are right. Okay. You know, I had a very strong discussion when I taught med-surg, because I remember using this question. And the student didn't agree with me because I usually discuss the question after the test with the student. Uh, and I need to become very firm, because you say you are not assuming what is expected versus what is not expected. You are not assuming the importance for a woman to have the information, to have the news that is having cervical cancer. You know, because, okay, the antiretroviral therapy is going to work very well. The purpose of this is expected that the CD4 count is going to improve while the viral load is going to be reduced. And of course, if the client have HIV, the ELISA and the Western blot need to be positive. There is no news here. The important stuff here is that the client has cancer. This is the priority in this question. Makes sense. Next, a client who is, esta es la misma. No, it is another. Okay, a client who is HIV positive and has a CD4 count of 15. My goodness, how low? The CD4 count, the CD4 count should be above 600 in normal people. If the CD4 count drops to 200 or less, then the client is going to develop the immune deficiency syndrome. In this question, they say the CD4 count is 15. It is extremely low. It is a client that is not receiving any treatment. So this client has just been admitted with fever and abdominal pain. You don't see this situation nowadays. Nowadays, the antiretroviral therapy, the highly active antiretroviral therapy is so efficient, is so good that usually clients with HIV have normal CD4 counts. Okay. Uh, so fever and abdominal pain. So is a client immune suppressed, immune depressed, and having fever and something in the abdomen producing pain. Which healthcare provider request does the nurse implement first? So what is the order that you carry out first? EKG, chest X-ray, blood cultures, and initiate antibiotics. Guys, obviously, the blood culture is the priority because of all this that can identify the source of the infection is the blood cultures. And the next priority is initiate the antibiotics. The other two tests can be done later. So the priority in a client with a fever of unknown origin and the potential intra-abdominal infection is to find which bacteria is. So the first is the blood culture, and second, initiate antibiotic. You cannot initiate antibiotic first and then do the blood culture because now the blood culture are not going to be useful. But this is the order. It is an easy question. I hope that everybody could answer properly this question if you have it. Well, in the hospital, the client has developed a vancomycin-resistant infection in the foot. Mhm. Vancomycin resistant is a big problem because usually we use vancomycin for resistant infection. So now we have a group of bacteria like the own Staphylococcus aureus that have become resistant to vancomycin. It's called Versa. So Versa, vancomycin resistant Staphylococcus aureus could be. The client has undergone surgical debridement for gangrene. Pobrecito. Which precaution is best for this client? Let's see. Wear gown and gloves to prevent contact with the client. It is correct. This kind of infection requires contact precaution. B. Assign the client to a private room with negative airflow. Is not necessary for soft tissue infection. There is no need of negative airflow. For infection that are spread through the air is when you need it, when you have airborne precaution. Wear a mask when working within 3 feet of the client? No, not necessarily. It is needed in droplets precaution. It is not the case. And the last, have the client wear a surgical mask when being transported out of the room? Is not necessary. What is needed is to cover the wound, if need to be moved out of the room, with an impervious, okay, dressing. Okay, contact precaution. Okay. The nurse supervises the staff caring for clients on the medical surgical unit. The nurse observes the student nurse enters wearing a gown, glove, and face mask. Okay, is wearing gown, glove, and face mask. in a room, is entering in a room. The nurse determines that the precautions are correct if the client, if the student nurse or nursing student, a student nurse is caring for which of the following clients: an infant diagnosed with respiratory syncytial virus. This is the RSV, and the RSV has been well established by the expert that is contact precaution. So there is no need of face mask. So this is not the correct. A school age child diagnosed with hepatitis B. Uh, for hepatitis B, you have standard precaution. So obviously there is no need of face mask. The gowns and gloves could be needed if you are going to do a procedure that you expect a splash, but it is not mentioned there. So it's not the client with hepatitis B. A teenager diagnosed with toxic shock syndrome. The toxic shock syndrome is standard precaution, so doesn't require face mask. Uh, a teenager diagnosed with influenza. Influenza is droplets, and influenza requires face mask. Is the most appropriate of that. The gowns and gloves are going to be needed if you are going to be exposed to for a standard to splash, to body fluids, etc. Because influenza, the same as the coronavirus, can also be transmitted um, by objects that have been recently in contact with respiratory secretions. So the one that justify wearing face mask here is the influenza. So if I were in my test, I would be choosing D. A nurse is preparing to transfer a patient receiving an antibiotic via a secondary infusion. Remember that secondary infusion is what we do when we have a piggyback. Remember, the primary infusion is the normal saline, the IV fluid, while the secondary infusion is the antibiotic or any medication that is going to pass in a short period of time. In this case, an antibiotic. So you are going to have, suppose, a higher, okay, bag with a secondary infusion is higher because it's going to pass first, while the primary infusion is lower. Okay, it is tested, so you need to know the one that is higher is the one that is going to pass first, and is the secondary infusion, and usually it's an antibiotic. And the primary infusion is going to be lower thanks to an extension that is used, and is going to pass only when the secondary finishes. So first pass the secondary, that because it's higher is going to pass first. And when you run out of liquid there, when there is empty bag in the higher, in the secondary, is when the primary start dripping, you start passing. But it's not the question. The PCP order a peak level after transfer, a peak level of the antibiotic. What information is most important to know by the receiving nurse? Remember that the peak levels need to be obtained after a dose of the medication. When you give a dose of a medication, the level in blood should increase. Yes. Why the level in blood of the medication increase? Because you just gave a dose of the medication. So you need to know at what time the dose was given to know when to draw the blood to see how the level is. The level is not going to be explored, is not going to be determined immediately after giving the dose, because it takes a certain time for the medication to be distributed and being stabilized in the blood level. So, for example, for vancomycin, it is 30 to 60 minutes after the dose, okay? But each medication have a different, okay, latency period to draw the blood after the dose, okay? Uh, so the question is, what information is the most important to know by the receiving nurse to know how to or when to obtain the specimen for the peak? And for, of course, is the uh, time of completion of the secondary infusion. So after the infusion ends is when the dose, the specimen of the blood is going to be obtained to do the peak. You understand? So you need to wait until the secondary infusion finishes. Suppose as in 30 minutes, going to be passed in 30 minutes, as the example previous. You need to wait that it finishes to then go and draw the blood to obtain the blood level for the peak. That is after the dose is given, after the dose is finishing. So the right answer here is C, time of completion of the secondary infusion. Sodium has nothing to do with antibiotics. The date of the client has nothing to do. It's so stupid. And result of the culture and sensitivity has nothing to do with the peak level of the medication. When the nurse is assessing the skin of an older client, which of these findings will be the most important to report to the healthcare provider? A multicolored lesion is present on the client thigh. Liver spots are present in both hands. Okay, the lay people, the street people, call the lentigo senile those spots, those brown spots that appears in the skin, in the dorsal of the hands of all people, call that liver spot. It is normal in the process of aging and it doesn't require to be reported. Cherry hemangiomas are scattered in the client's back. You need to know that very white people, the people that have a very very fair skin, uh, have a type of skin tags of skin moles. Cherry angioma, cherry angioma, okay, cherry angioma. Okay, and these people develop multiple as aging in the trunk in areas that are covered. Develop no, it's not tell me when. Those are the brown spot, the lentigo senile, and the cherry angioma. Okay, um, multiple red uh, small elevated papules, okay, that appears in all the body, okay, appears in all the body. Those are okay, okay. Um, uh, don't confuse this with the strawberry angioma that is seen in children as a congenital condition. This cherry angioma appears in as you grow older, okay, as you grow older, uh, um, normal, okay. The strawberry angioma, okay, the strawberry angioma is different. It's a solitary, um, okay, it's a solitary um, elevated big you know lesion that tends to grow uh, generally with with irregular surface, is much bigger and appears is congenital, is born with the child, okay, and it's benign also. It has no implication, but it's more aesthetically when it is in the face, is more aesthetically cumbersome or inconvenient. No? It's different. Okay, just a comment. Okay, because sometimes, okay, um sometimes it confuses you. Okay, this is normal. Okay, cherry angiomas in the client's back is okay, it's normal, it's the same as the liver spot. And the skin on the extremities is paper thin. It's very common when you grow older that in the chin here, in the extremities, the skin is very thin. So a lesion, a mole that have different colors could uh, classify or could fit in the description of A, B, C, and D that are the criteria for skin cancer, for malignant, okay, modes. And you know that A is for stand for asymmetry, B for irregular borders, and C is different colors, okay, irregularity of the coloration of the lesion. So this is a criteria of malignant mole. For that reason, should be the first to be reported of this client, while the others are expected in aging process. Learn these A, B, C, D, E criteria for skin cancer is frequently tested in English. The nursing instructor review instructions with the nursing student on caring for an older adult with risk for a pressure ulcer. What action by the nursing student indicates a need for further instruction about proper skin care for this client? Let's see. Carefully massage bony prominences if reckless. Never, never provide massage of the skin of bony prominence. Recommend use of condom catheter if incontinent. It is correct. Condom catheter is a non-invasive method for incontinence control in males. It's very useful and is low risk. Reposition the client every hour. Okay. Repositioning the client every hour could not be enough. You know there is a scale called Braden scale that considers several risk factors like friction, tearing, pressure, incontinence, nutrition, sensitivity, mobility, and give a score that tells you the lower the score, the higher the risk. That gives you a higher or lower, but quantifies the risk. So there can be a very severe risk. In clients with very severe risk of skin breakdown, like clients with less than 12, for example, those clients changing position every hour is not enough. And then you'll see that the expert, the wound care nurses, prescribe, and the doctors prescribe a bed, a air mattress is called, that is continuously inflating and deflating in different segments to move the client, to change the pressure in the of the clients continuously, not every hour, not every 2 hours, but continuously. So repositioning clients every hour could not be enough, okay? Could not be enough, okay? But it depends. But at least is not wrong. And using a moisturizing lotion, there is no problem using moisturizing because keeping the skin moist is okay. So with the comment that it depends on the braiding scale. Every hour could be enough or could not be enough depending on the magnitude of the risk of the client. Being sure that condom count is okay. The worst recommendation here, the one that requires, okay, for the further instruction, further correction, is the massage bony prominence. This favors the development of pressure ulcers. And the last that I have for you is a 6 years old who has asthma, is showing a prolonged respiratory phase and wheezing, and has a 45% of the best personal peak expiratory flow rate. When you have less than 50%, less than half the expected volume of air that the client is able to blow in the peak flow meter, the client is critically ill. The question here, what action should the nurse take first? What you do first? You have here determined triggers of this attack. It is a waste of time in this moment. It's not um, enough for the emergency of the situation. Encourage the client to cough and deep breathe is not enough to address the emergency of the bronchoconstriction and the respiratory distress of the client. And then you have two options: transfer the client to the emergency room and administer a prescribed bronchodilator. But they are asking me what I do first. Uh, I hope that you understand the first, I administer the albuterol, okay, because it can improve the client. Meanwhile, I second transfer the client to the ER or call the 911 to be transferred to the ER. So the answer to this question should be D as in David. The first that I do is administer the albuterol because can improve the client and give me the time to transfer the client to the ER, which is the second. Okay, so those were the questions that I found in my old document of MedSearch that I used to practice MedSearch with my students, trying to please everybody that people prefer to practice questions while we refresh concepts and to help the people that are also taking MedSearch. Okay, so this is what I have for you today. You have any question, any doubt? Are you okay?
Thank you very much,
Thank you
Professor.
so much,
Thank you.
Okay,
Professor. Thank you so much.
so my pleasure. So see you next time. Let me check quickly the
Well, thank you.
attendance. Okay, so okay, people and okay, perfect. Okay, that's it. Bye bye. Bye, Young.
Bye, thank you.
Bye bye.